I'll make you feel comfortable. Welcome, doctors, to the program. My name is Ray Gibson. This is the Breakfast Show on News Talk K57. As we've decided to do for the majority of days this week is to have kind of a meet the doctors panel from some of the big thinkers that we brought in over at the Guam Regional Medical City. And I'm not sure exactly how we're bundling them up. Yesterday I just had the one guy from the one Chinese guy, and today I've got 3 Colombians in the studio. But I'm saying it right. It's Colombian. Isn't it? Did I get that right? I want to make sure that I get that. And so I'll start with the introductions first. The lone male doctor in the studio this morning, Jose Gonzales Huertas.
Yes.
I did that right?
You did right.
You can thank Frank Campillo. he's the one that he took me to school on the pronunciations of Hispanic names. And then there is Dr. Isabel Acevedo Villalobos. Villalobos.
Muy bien.
Thank you very much. And this one here that I suffered through because I thought it was Varela, but it's not. It's Varela. Dr. Ana Milena Sanchez Varela, and all of them doctors over at Guam Regional Medical City. First of all, welcome to Guam.
Thank you very much.
Isn't it a nice place?
It is.
Yes?
Thank you very much.
What have you found to do here that's exciting besides going to work every day?
Many things. You know, the beach is beautiful. Snorkeling is excellent. Just eating is just the food here is amazingly
I want to compare and contrast a little bit because we're all basically children of the Spaniards that found their way to the countries all of those years ago. So I'm sure that there's many similarities in the food that you enjoy here. Plus, what you've got at home. Right, there are a lot of.
That's correct. So the yellow rice, or that's what we cook in Colombia. That's what we do, but it's similar to the red rice.
Right.
So meat. Colombia is also big in meat.
See, I'm glad to hear that because the WHO this morning just came out with this thing. I was laughing with the doctors before. I'm really upset about this because it sounds like they're trying to criminalize meat all of a sudden. And I'm telling you, you guys are doctors. You know, evolutionarily speaking, we probably wouldn't have come down from the trees if we hadn't started eating meat, right?
Well, everything in moderation.
I'm looking at the pathologist.
It's a matter of moderation also, and you like processed meats. That's where the problem is. You know, like if you go and they add all these chemicals to the meat, that's where it becomes all the cancerogen things. So if you
but that's where the flavor comes from.
It is, but then there's consequences, and then you may be exposed to all these cancer things and you may develop a disease.
Okay, I don't like that answer. What's your answer, doctor? Let me check with Jose.
It's moderation, yeah. I mean, the actually natural. I mean, just appeal to natural. I mean, I think there's nothing wrong like eating meat like once or twice a week or more than that.
I'm telegraphing a different answer to him with my eyes. What do you mean once or twice a week? But once a day. Yeah, well, but again, I suppose, and much of it is in the preparation of the process. I mean, if you're eating a lot of processed meats every day, that's going to be bad for you, whether it's cancer or not. There's going to be something that's going to catch up with you eventually, and you'll need to go see the doctor about it. But I mean, there's other natural ways that you can process, that you can prepare meat. I was bragging the other day about a friend of mine who likes to dry meat, and he'll take the meat, from the store and lay it out and put screens over it to keep the bugs away from it, obviously, and then dry that. Just a little bit of salt and pepper, some basic seasonings on it, and then you dry it some more in the. My mouth is watering. And then you dry it some more in the oven, and you dip it into a really, really good sauce, and you're good to go. I mean, that kind of basic preparation.
Well,
nothing wrong with that, right?
That's safe.
Yeah, and it's tasty. So we'll take it from there. I'm kind of curious about something else. I've talked with Frank many times about him growing up in Colombia, and he goes back from time to time, and on occasion, I'm kind of curious though. What is access to health care? What is medicine like in Colombia? Is it something that we as Americans would recognize?
Well, I think Colombia is still an underdeveloped country, and there's a lot of problems with health still, with the health system that the government is trying to fix. So it's very different how it's here in the States. Like, we all went to medical school, and then at the end you have to go and work for a year as a year to service to the community.
Okay.
And then if you want, you can go into residency. It's very different from like the United States doctors. I would say pretty much all of them go into residencies. In Colombia, people have to make the choice to go, and they have to pay for doing that. So that's why we end up living with our parents till we're like 35, because by the end of our training, finally we graduate and we can work. Before that, you're not reimbursed.
Now that community service, is that in healthcare? I mean, do you go there and take what you learned from medical school and apply it on kind of a clinical basis?
Yeah, exactly. It can be in very isolated places, like up in the mountains in Colombia. So yeah, it's actually challenging, but at the same time it's rewarding, because you learn to work with little resources.
And I hear some of the same things from doctors from around here from time to time, because of a lack of resources, one way or the other. You've got to do more with less. You have to be a little bit more creative and original when it comes to doing some of the treatment on the patients, because you might not have everything that you would have in a United States facility or a larger city facility, right? So you've got to be a little bit more on the ball that way, right?
Exactly. You need to be very good clinically, and because you don't have let's say x-rays or something like that, so you have to work with what you have. It's
hands-on to be sure. How do you get from there into the specialty zones that you're in? Because it sounds like from after your time is done and that you go into what's basically almost general practice. At some point, though, you decide you want to be a pathologist. At some point, you decide you want to work in oncology with children, respiratory issues and things like that. How do you go from that into being a specialist, Doc?
So when we finished our training in Colombia, we came for residency here at the United States. So I did a pediatric residency, which is a 3-year training just for children, just to treat their diseases. And then if you want to go further into training, then you do something that's called a fellowship, and you do 3 more years of specific things. So, for example, he did pulmonary and critical care. I did hematology and oncology, so to treat kids with blood diseases and cancer. And then Isabel did cytopathology, which is a specific thing in pathology. She'll explain.
She's going to need to explain that, because with you two it's easy. There's a blood and kid diseases, and with you it's all respiratory and just making sure that each breath that I take in, I'm able to exhale, and my body is able to process the oxygen and do beneficial things with it. And I tell you what, you don't know what you're missing until all of a sudden it gets very difficult to breathe at some point, and you don't know why or don't understand what might be the causes of those things. And unfortunately, in the world that we live in, and I imagine in Colombia, it's probably even a bigger deal. I imagine, in Colombia.
Maybe not.
Yeah.
Cigarettes they're more expensive in Colombia. Actually, Guam probably has a higher rate of
cigarette smoking.
Cigarette smoking. Yeah.
We have expensive cigarettes here as well.
But
they have money to pay for it.
I suppose, Well, the way it works here is there's many people that have government assistance, so they use the government assistance to buy food, and because they're not spending as much money on food, they can buy cigarettes and booze. I know it's one of those things that it's a little challenge that we've got to get through and get a deeper understanding of. That being the case, though, as you look at respiratory illnesses and things like that, you've got the easy ones. Are you discovering, are we learning more tough things that are happening to our lungs in our modern society that we're going to have to get over?
Yeah, mostly tobacco-related diseases like COPD. I mean, the cigarette smoking is pretty bad for your lungs, and not only for that. I mean, it's also associated to cancers, lung cancer, mouth cancer, stomach cancer. So it's...
That's why I quit.
Yeah.
I replaced it with running. Thank you very much. And now he's actually you've written on smoking cessation.
Yes.
Can you make it easier? that's the tricky part here, and I know that there are so many people that have tried in multiple ways. My smoking cessation program involved stopping smoking the cigarettes, and then I went to the gum, which had nicotine infused into the gum, and that cost too much money, so I went back to tobacco, but I went back to chewing tobacco and eventually weaned myself off of that until I didn't need it anymore. And it was a very, very long process. Are we making any inroads among the scientists in the medical community with cessation aids that are working better?
Yes, especially medications. They have been shown that they're more effective. There is a higher rate of quitting when you use medication and when you are involved in like a smoking cessation program. So, like cognitive behavioral therapy. So those elements are very are proven to work.
Is there a method yet, Doc, where you can give me a pill and then I'll go to sleep and I'll wake up, and when I wake up I will have broken the habit? Do you have that yet?
No, unfortunately, no.
That would be a good thing. Well, like I said, and we've got a pathologist here, and I think I understand the concept of pathology and just trying to understand diseases and how we get them, how we treat them, and how we cure them. But it seems like such an academic jump. It seems like you should be in a university hospital as opposed to this one here.
Well, pathology is like a big area. We are divided into big areas. One is anatomical pathology, and the other one is clinical pathology. So the clinical pathologist supervises and oversees the operations of the laboratory. So when you go and you get your glucose check, your cholesterol check, all these instruments have been calibrated and have been prepared to make sure every test, every result is accurate. That if your glucose is 90, is really 90 and not 120. And all those numbers are critical because once I give you a result, a clinician may say, you have diabetes based on this result.
Exactly.
So all these machines, everything needs to be, and there's a very specific way things need to be done. And all of that is supervised by the pathologist in the clinical pathology section.
So if I were to receive a blood test, urine test, fluids, all of those things, they would go into your domain, and there's a beautiful lab at Guam Regional Medical City. There's equipment there you won't recognize, but it does something important. It does mass spectrometry or whatever it is. And then we didn't buy that one yet?
No, yet.
They have it in the cafeteria. Maybe it's not in the lab, but I think it's in the cafeteria. But they do things down there that I could not begin to understand, so that you can determine what exactly is wrong with the patients based on the symptoms that they're presenting, but also what the fluids are in their body.
Exactly, yes. So right now we have all those machines ready to run, like what we call chemistry tests, like glucose, like your protein, triglycerides, all those chemicals in your blood, and also we can measure on your body fluids, like somebody has like a pleural effusion in the urine or whatever. We have all those equipment to measure things. Now in the anatomical pathology area, what we do is like a surgeon takes a biopsy or an oncologist do a bone marrow biopsy, and then we looked at it under the microscope and tell you a diagnosis. So for example, Dr. Sanchez has a patient and she thinks the patient may have some type of leukemia. So she makes the bone marrow biopsy and give it to me. We process it in the lab, and I look in the microscope and I tell her, I think it is leukemia or it is not leukemia, it's an infection. So we pathologists, we're not in academic centers, we're in everyday labs. But
you're working with the actual parts, the things that come out of the patient. You're working with the fluids. You're working, with a piece of tissue that may have come out of the patient.
Breast biopsy, prostate biopsy, a colon. I looked in the microscope and I will tell the clinician, I'll call Jose, hey, this patient has a lung cancer, so please send it to the oncologist.
And where do we? You are obviously at different stages in the game. How does what you do with your pathologies? How does that work with some of the other diagnostic technology that they have over at GRMC? I mean, there's some incredible imaging that you have.
Yeah, everything is very well. We need to have a perfect communication with the clinicians, and then the doctor actually doing the procedure. For example, a patient has some collection of fluid in their lung that Jose identify, and then they send it to an x-ray, and then our interventional radiologists take the fluid, or maybe Jose does it himself. So they need to tell me specifically what type of procedure they're doing and through what technology. Was it a CT guided biopsy, or was it through x-rays, or was it on their sonogram that you took it from? And then because we have all this technology in the that we can see now all these lesions, they can make the biopsies and send them to me.
And once we've got this whole package of data for the doctor, then we can be pretty sure of what the next steps are going to be and how we're going to take the patients through a number of different surgeries. So near as I can tell, you guys are kind of indebted to this lady here. And so between the other two doctors, I'm sure that they will be able to keep you busy by sending all of the lab work down to where you are. I'm get fascinated with the concept, primarily because I don't know as much about chemistry other than what I learned in school, and frankly, it all sounded like mathematics to me, so it was difficult for me to follow along with. I'm glad, though, I don't need to. How much of the process anymore, and I ask you to speak directly into the microphone, if you will, how much of the process is automated? When, where you take the fluids and you just stick it in the machine, and then it comes out at the other end with a printout.
Yeah, so when you just give a sample of blood, the machine itself, it is automated, but you do need like a technician to do the whole process, to put it there, and then you need to supervise that the machine is doing correctly, and it needs to run controls every single time. So you still need technologists to supervise the process for a blood test to run any blood test. Actually, we have positions open. Now that you said that, so if you're a technician or a technologist,
if you understand what the thing is, and which buttons to push, and how do you know if you run it through and we've got some bad results here? I mean, the false positives, things like that. How do you adjust for that?
Yeah, this is very regulated machine, and we run controls to make sure the machine is running the way it's supposed to be running, and they run the controls every day, and sometimes they run it with every time the machine runs, and the controls are very good, are specific, created just for this specific test, and then that's how we know the results are good. And our lab, we're working with all the regulations of the College of American Pathologists, so we follow all the instructions, and we follow all the regulations to make sure our test the results are accurate and correct. So
and again, that's what's needed, because eventually the results are going to go back to Jose. Then that will determine how Jose deals with the patient that's in front of him. And in the case of Dr. Anna, who is working with children and life-threatening diseases, because once we get into issues with poisoning in the blood and the marrow and places like that, that's where things get very serious very quickly, because it seems to me that after that you don't have much time to save the patient.
That's correct.
In a lot of cases, especially in pediatric cases, where we're talking about young people who might not have their whole immune system together at the time.
Yeah, that's correct. So that's why it's very important to actually the support from pathology and all the other disciplines in the hospital are very important. The radiologists, the surgeons, if there's something that needs to be removed, a kidney tumor, it's very important to have a great pathology service, because those samples have to go, and we have to make sure that we have a right diagnosis to be able to provide a right treatment.
Now, it's not. Is it specifically pediatric oncology that you do, or does that kind of split? I mean, if somebody like me were to come in and all of a sudden the numbers coming back from this doctor said, yeah, there might be a touch of something in the liver, might be a touch of something in the lungs, you could take a look at that and oncologically determine whether I might have an issue with cancer.
So for my specific specialty is pediatrics, and it's combined with hematology, so just benign diseases of the blood. Not all diseases of the blood are cancer.
Oh, I see.
So you can have anemia, like a nutritional deficiency, like iron deficiency anemia, and that's also on my area of interest or treatment. You can have problems with your platelets, which are very important specific cells in your blood that helps to prevent bleeding. Clotting factors, patients with hemophilia or bleeding disorders are also things that I deal with.
Yeah. I don't think I'm a bleeder. We've had bleeders in the family, but I don't think that gene has gotten down to me. But it's one of those things that you always hear about when you're a little kid, and it just freaks you out, that the fact that you might be able to get a cut somewhere and never ever be able to stop bleeding or be able to clot is stuff of legend among children.
That's correct. So that's one of the parts of the hematology, benign hematology, not only oncology part that I do. And I also help with the pediatric service in our hospital.
How did you choose that?
How do I?
What's the thought? Because I mean, you all start basically as a blank slate in medical school, right? I mean, and then at some point, like I think in a number of career paths, you might say, I like this kind of medicine, or I like to work with the respiratory system. What was it with you? You said I want to work around kids.
I guess for every doctor depends on the experience that they have early on during their career and the people that mentor them. So if I have very specific cases that were very touching to me, and I thought it was very interesting to be able to just go actually under the microscope and look at the cells and being able to fix it and help them. So I guess that happened early when I was in.
Do you ever get to cut anybody?
I perform bone marrow biopsy, so that's a little bit going into the bone, but that's the most that I do.
That sounds like among the most painful. Both of us are on the blood donor list.
Excellent.
We're on the donor list for bone marrows and have been since we had the opportunity. And then I heard from somebody that got pretty close on a donation to be a donor, and the stories that she was able to come back and say, oh yeah, this is not a painless procedure.
Well, no, they do it under sedation, so I don't think it should be discouraged to people to be donors. That's excellent to be on the register. You know how it's a life-saving. You're basically saving these people, this little child life, this adult life, because if without the bone marrow, you'd never think of it. But all your blood comes from there, and your blood is just everything that you need to be able to take the cells, the oxygen from the cells, the oxygen that you take from when you take deep breaths. The only way that they can go to your body is through the red blood cells, and that's produced by the bone marrow. So it's so if
you got sick marrow,
it's a very important organ for you, and it's great that there's
we've got a big bone marrow registry here on Guam, and we've worked very hard to maintain it where we have.
Excellent.
Well, you'll be happy to know that now bone marrows can be done also donations through your veins. So days before, weeks before your donation, they give you some medicine to get your bone marrow going, and then just with a simple blood donation, you can donate bone marrow. So bone marrow donation is not.
We don't have to dig into the bone or cut the crust anymore.
No more digging. Now there's ways to do different types of bone marrow donation just through your veins, like if you will donate blood. So please, everybody donate.
Yeah, get on the list. Most people that have been able to sign up have signed up. You know, outside barring any of the other predispositions, anybody that it seems to me that could has in the past.